Good evening, everybody. I'm Pragya Saini, and the topic for my presentation is long-term outcomes following the management of incomplete punctal canalization. Going back to the basics, the punctal canaliculi, they actually develop when between the nasal and the medial and the lateral nasal processes at about 30 mm stage of the embryo, where the lacrimal canaliculi start forming. Initially, they are completely solid structures which start holofying at about 135 mm stage at 6 to 7 months of embryogenesis, and then at 9 months or during the birth time, that's when the apoptosis is complete and they're completely holofied. We don't exactly know the pathogenesis of incomplete punctal canalization yet, but our hypothesis is it's during this hollow apoptosis that is occurring. It's during that time when the incomplete punctal canalization occurs due to incomplete canalization at the punctal level. So we classified it into internal membrane variant and external membrane variant. The internal membrane variant is a membrane which is present just in the internal punctal canal. It is a non-vascular membrane, and on OCT it is seen as a hyper-reflective membrane, and below we can see a hollow canal. The external membrane variant was a little more superficial, in line with the external membrane of the punctum. It was with or without vascularization which was present. Later on in 2014, we found an balloon variant, which was a dome-shaped elevation was present over the puncta. So this is a part of the external membrane, and it's another variant of that. Our methodology was a retrospective intervention study over the 5 years period in January 2015 to December 2020. We used a Nettleship punctum dilator rapid tapering first, followed by slow tapering punctum dilators. Our data included the demographics, clinical presentation, laterality, type of the punctum membrane, associated abnormalities, and management modalities and long-term outcomes. So we first use a rapid punctum dilator to make an opening in the membrane. The slow punctum dilator was done to complete the membranotomy, and on histopathology we saw it as a fibrocellular membrane. On demography, we actually included 98 puncta of 62 eyes of 46 patients, an average age of 12.5, with a female to male ratio of 1:1. So this is the methodology as explained, and here in the end we have like a complete hollow punctum seen on slit lamp. So the patients, they presented with epiphora since birth, about 70% of them. Bilaterality was seen about 35%. All 4 puncta were involved in 16% patients. Both upper and lower puncta of the same eye were involved in 55%. Lower puncta was slightly more, which was 54%, and the upper puncta 46%. The external membrane variant was slightly higher, which was the same as the study published in 2014. And internal membrane was slightly lesser, 38%. 78 puncta of 39 patients underwent membranotomy. Associated abnormalities were seen in 31. So we had 3 puncta who required mini Minoka stenting, out of which 2 required partial canalicular, 2 had partial canalicular obstruction, and 1 had canalicular stenosis. We had 5 patients who had associated CNLDO, out of which 3 underwent DCR for bony obstruction, and 1 patient had a 3-wall canalicular hypoplasia, for which we could not do anything. 3 patients had associated punctal agenesis involving the other punctum of the same eye. And a total outcome, anatomical outcome was 100%, whereas the functional was 97.4. What did the study add was that it validated the earlier management protocols of membranectomy being the primary management, and newer associations like canalicular wall hypoplasia and punctal agenesis was noted. So the insights that we gained was that membranotomy works best if the first puncture into the membrane is performed by a fine dilator, followed by a slow taper dilator. It should be complete membranotomy without any overhanging membrane or residual membrane present. Unlike punctal agenesis, it was not associated with any systemic disorders, and it was rare to encounter functional failure post-treatment. So that was just 1 patient. Thank you.
Thank you, Dr. Grover, sir.
So what was the association? Would you repeat that of canalic of the punctal membrane with canalicular agenesis?
Could you get my PPT again, please? So, okay. So we actually saw that the other punctum had punctal agenesis present here.
About the association with canalicular non-canalization, how common was that? The punctal.
So only three patients had
So
canalicular
most of
stenosis.
these were just the punctal membranes,
Yes, sir.
which
Yes,
could
sir.
be easily overcome just
Very
with a
easily.
punctum dilator.
Yes, sir.
Dr. Pragya, I'm no lid specialist,
Yes,
but being a cornea specialist, sometimes I have observed that in addition to the problems with the punctum and the canaliculus, we've seen in some patients the opposition of the punctum to the globe has been a reason for epiphora. Means the punctum is not flush with the globe, so it's not able to drain properly. So did you find this condition in any of your inclusions? And if so, we found that very difficult to kind of address as a problem.
Ma'am, ours was it was limited to the incomplete punctal canalization. We have had such the problem of lid oppositions and all in patients with punctal agenesis who are completely agenetic and not incomplete in this our criteria. But just these patients do not have such abnormalities. They are absolutely normal, absolute normal caruncle, absolute normal lid margin. And just one patient had a canalicular wall hyperplasia for which we could not do anything. But other than that, the lid was completely normal, ma'am.
Okay, what would be the difference in the frequency of the agenesis that you've observed versus the membrane? For punctum?
Sir, of the 98 puncta that we observed, the agenesis was only in 3 patients.
So most of the cases are just manageable by a punctal dilator.
Yes,
and do not require any snips or anything.
Definitely, sir. And rapid and a slow, so that a complete membranotomy is done, so that there's no recurrence and the membrane does not.
And which cases did you choose to put in a stent?
So there were canalicular stenosis, partial canalicular obstruction where we did trephination followed by stenting, 2 cases of that, and 1 had canalicular stenosis, so we did stenting in that.
And the results in the follow-up, how long have you followed?
Sir, I followed them up for 6 months, 100% normal. And overall, they were followed up for about, for the 5-year period, so they followed up the maximum, but on an average, it was 6 months.
Balaji? Thank you, beta.
Thank you.